Hi, I'm Robert from the World Health Organization Forum on Health Workforce. We've got various members of Wonka Brew here. We've got Paul Worley, who's the representative for the
Australian government.
I'll let everyone introduce themselves to you, starting from the left.
Hi, I'm Shelley Nolan. I'm the Chief Nursing Midwifery Officer for Queensland, and I am here representing my state in regards to supporting rural and remote nursing and integration.
I'm one of the co-leads of Rural Seeds and currently training in the UK.
Strasser, previously from Australia, but since 2002 I've been in Canada as the Dean of the Northern Ontario School of Medicine.
I'm Amber. I'm from the Virgin Islands and I'm part of Fonts University Rural and Remote Health and Medical Education track, and now a junior doctor in Competency Hospital in Wales.
My name's Nav, I'm a medical student.
Speak loud.
Yeah, the microphone's this. Big voice.
My name's Nav, I'm a medical student studying in Ireland, originally from Toronto, Ontario. And that's pretty much it.
I'm David Schmidt. I'm chair of the Department of Family and Community Medicine at the University of North Dakota in the USA, and also president of the National Rural Health Association.
So I'm Yvonne Yak, and I am not a physician. I'm a healthy economist. I might be a well-raised university. But my specialty is really rural and
you need to speak a little bit louder. We cannot hear from the online transmission. Who is in the back? So.
G'day, I'm Paul Worley. I'm a rural doctor from Australia and presently the National Rural Health Commissioner for Australia as well.
Hi, I'm Tim Rourke, a rural doctor from Canada, former Dean of Medicine in Canada for Rural Medical School, and currently the Society of Rural Physicians co-lead for a Rural Medicine Action Plan.
Hello, I'm Bruce Chater. I'm the secretary of Rural Wonka, the Wonka Working Party on Rural Health, and I'm also the professor of rural remote medicine at the University of Queensland in Australia, and proudly a rural doctor in a very remote area of Australia as well.
So where is Theodore?
Where the hell is Theodore? It's 600 kilometres inland from the capital of Queensland in Australia. So, but in Queensland terms, we're only 1/5 of the way across the state, so we're a fair bit bigger than Texas.
The people that have joined us like to quickly introduce themselves, say where you're from, and shout.
Your biggest voice.
You need to scream.
Need to scream.
You need to speak up much louder.
Well, until people will come, I can introduce myself. So my name is Mayra Foz. I'm a young doctor. In 2015, myself, Amber, and Veronica and Sarah Strasser created the Rural Café, which you are participating now. Until now, we have more than 40 countries participating and more than 100 people joining us in different ways and occasions. So we are really, really happy that we could manage to have this session and to discuss rural and interact. I will be coordinating the Twitter feed, so you can use the hashtag Rural Café. And also we are on the Facebook, so you can also interact there, and we will come and bring more the opinions and bring the ideas to the round for the discussion.
Right, I think we might start the discussion. So the theme for today is what would the rural workforce of the future look like for rural healthcare? And our first kind of question to think about is who will be involved in primary rural healthcare? So if anyone wants to give some thoughts.
Wow. This is Julia Mandia. I'm from Zimbabwe, and this one is and I also trained with the regional.
Can I just ask, when people are talking, if you can stand and really project, because Mayara can't hear anyone past the second row. So do you have any thoughts of who should be involved in rural healthcare, or who is currently involved in your areas?
I can add my 2 cents, yeah, and come in the front row. So who I think should be involved, I think it's firstly the people who live in the community, because they know what their needs are and they will become food for your human resources. And then people who are dedicated and interested in taking care of that community. So they may not necessarily be people from that community, but they have to have a vested interest in the welfare of that community. And I think together, those two forces will determine what the needs are and how best they can be met given the resources that they have. So right now, working in Wales, our biggest sort of coordinator of rural healthcare tends to be sort of a mix of the GPs, the leaders of those communities, and the district nurses, because they're the ones who are actually on the ground visiting people's homes. And they give us a very good idea of what's happening, what's the best thing we can do, what needs improving, and what strategies we can actually implement to make a change.
Anyone else on this group?
Thank you very much. In Zimbabwe, we have got World Health teams that would include the community and the practitioners, health practitioners at the rural health centers. So they meet on a regular basis to discuss what they need and how they can remedy any challenges that may be in that community. So for me, you want people involved in their own care, and then you provide them with maybe specialists in the different aspects, maybe rehabilitation, maybe nursing, even doctors who visit from time to time. They may not be residing in that area, but visiting on a regular basis and attending to the needs of those communities. I think would be the best way forward. Thank you.
And maybe to add, we need maybe to have the community leaders are involved, so that we can actually attend to the cultural beliefs and cultural aspects of health, because we are going to be attending to. And it is also important because they will listen to their leaders. If the leaders talk about it, they will actually believe it more than having an outsider coming in to talk about something that is pertaining to their health.
Any other?
In the United States, looking at rural healthcare, we said something very similar, because we found that sometimes people trying to help from the outside who weren't aware of the resources in the community actually sort of bypassed the good things already happening in it. So by starting with the community leaders and the patients who are people in those communities themselves, they can better communicate what is already working for them and how outside resources would be helpful. And that may be very important, especially with growing technology, to make sure that we're not breaking down what's happening already. At the same time, we're trying to build up what could even be better, perhaps.
Anyone else?
Just one other point. I think with that twisting your neck around there, I think when you've been in a community for a while, you actually become a member of the community, and I think that really helps. And so that's what we should aim for, is for doctors, nurses, and others to want to stay in communities and actually feel what it means to be a member of that community. I think particularly looking at the young doctor aspect of this, I was just reflecting this morning that having these rural centres, these rural hospitals and practices as really important teaching centres makes a difference then for the students and the young doctors too. So you can develop, you get over a lot of that isolation by, even in small places. We had only myself as a doctor when we first went there. Now we have 2 family medicine trainees, an intern, 2 medical students. We're probably going to have a nursing student next year. So actually having those in the community helps me to enjoy my practice. It helps the students to have a community of learning. It also helps them, all of them, to understand what's happening in the community and actually be community members and be invested in that community. So I think that's a really important part of us having a viable way forward for training in rural areas and invigorating rural areas. And having what Roger's shown, I think, is that increases the economic output of the community too, because you're not going to get teachers and others to come to communities unless they know they've got a good medical service that's intellectually good, as well as just, you know, being there, but actually has the highest of standards. Roger, did you want to mention anything about, I know you're going to be talking tomorrow about it, but some of the economic advantages of that?
I wasn't thinking of it just now, but I can mention that, sure, Bruce. So what we've found with Northern Ontario School of Medicine, where our students in medicine and other fields and our trainees, residents actually are living and learning in these communities, the rural and remote communities in Northern Ontario, is that the existence of the school has actually been an economic benefit to the communities. Just to give you some figures, last year the budget of the school, the taxpayers' money, was $43 million. The level of new economic activity, over $100 million, so more than a 2-for-1 multiplier effect. And that economic benefit is there in the small communities, more or less proportional to the number of learners that we have in any particular community. So that's the particular point that Bruce was picking up. I do want to also reinforce Bruce's point about rural practitioners. By and large, they live in the community they serve, so they're part of the community and have an acute awareness and understanding of what the key health needs are of the community. So tend to work together in teams and to respond to and address those community health needs. And to pick up on Dave Schmidt's point, my observation is that the role of specialists in relation to service providers in rural communities, it really works best where the specialists are true consultants. That is, they support the nurses, the doctors, the other health workforce in the rural community to be the providers of all care, the first line providers of care in the community, and the specialists support the local providers and support them by providing education, by case discussions, by shared care sort of models, rather than coming in separately from and interacting with people in the community separately from the local providers of care.
So now that we've talked about what we would like to see happening, what are some of the obstacles that you're facing in your communities to achieving better primary care for rural communities? Yes, Mayara, you can comment.
Okay, thank you, Veronica. I just want to say that I'm a young doctor just graduated in Brazil. If I didn't get a chance to meet the people there in front, Veronica, Roger, Bruce, John, in 2015, I would never have a contact with rural. I got it by accident and not because I was exposed on my training. And it's quite hard to be a rural doctor in Brazil where you don't have internet, where you are working, and I don't have a professor coordinating myself. So I'm quite alone on that and isolated and remote. And it's great that I have support of people that we are discussing here and that we are able to keep talking and growing. So being rural, it's really different in different places being rural in Brazil, isolated Brazil, is different than Australia, than Canada. And we need to be aware that we are not getting ready. In my training and in the training in Brazil, we are not getting ready to go rural, and people go by accident as well, and do not know what's going to happen, and do not know what's you're expecting. And we need that workforce is more prepared, and we need to discuss rural intensively and bring to our grades and bring to our curricula. This is essential. So just to reinforce what you were discussing. Thanks.
Does anyone else have any experience about difficulties they faced in trying to establish better rural care for their communities, rural health care? Anyone?
The biggest challenge, particularly in like places like Zimbabwe, is the network, the road network. The accessibility can be the real challenge. Communities are also not that rich, so they may not be able to pay for services. That can also be a challenge. We haven't established where there are community clubs now for them to be able to, but I think that's the direction we want to consider, that people can actually form clubs and contribute on a regular basis, so that when any one member falls sick, they'll be able to assist. So transport, especially when people develop complications that may need higher care, the road network may not be as accessible as we want. The other challenge is also the resources in terms of maybe the medicines to get out to the rural communities may also be a very difficult area. We use community health workers. They are not remunerated. Sometimes they may need the resources for them to go around as well. So maybe motivation and even training them on a regular basis. So those are some of the challenges that may be there, because there's limited funding for such activities. So that is an area which we believe would be improved if funding was available, training rural health workers, and to probably have even facilities that are much deeper in the rural communities. Then they don't have to travel any longer distance. So you minimize the need for better road network. I think that would, to me, would be a very important issue. Thank you.
Does anyone else have any thoughts?
Well, a theme from these last contributions is about infrastructure. So limited resources of all kinds, financial, but also physical, in terms of whether it's transportation infrastructure or internet communication infrastructure. That's certainly one of the challenges that's common in remote and rural areas really around the world. And I guess I'm an optimist. I see that as a special opportunity and something that means that as a provider of care in these rural communities, it reinforces the importance that the care providers, the rural practitioners, are really prepared and able to provide a wide range of services, and they are carrying, compared to their metropolitan counterparts, they're carrying a higher level of clinical responsibility and relative professional license.
Bruce and I flew over from Australia, and we were talking about our flight time was 26 hours from the time we started to finish, and it takes longer than that to drive from one end of our state, Queensland, to the tippity top. And the theme here is the tyranny of geographic distance. And nurses in Queensland, it was raised yesterday that Australia has the most amount of for the population, and we're quite wealthy in that regard with numbers. However, where the jobs are in the isolated areas, in the rural environments, and to get our nurses to work there, we needed to have collaborations with medical officers and allied health and produce those relationships that supported each other when you are isolated. And secondly, use technology in a way that could bring education to support the nurses and doctors. One of the things that we did in Queensland was put 3 educators in the capital city that worked with the retrieval service that works 24 hours a day, 7 days a week to collect patients. and we just set it up for our graduate nurses to encourage them to go and work in rural areas. And now we've had up to 500 visits per week in the phone up to find out how to do a skill by doctors, by allied health, by nurses. So by actually taking a little resource and sharing it globally throughout the state has benefit to support and keep people in those rural areas.
I think one of the other special opportunities for young physicians and students is around leadership development.
Yeah.
And if we can inspire our new community leaders in rural areas, I can tell you when I moved to my small town of 2,000 people, far away from any metro center, we had just gotten our new cell phones. There were these things called cell phones. They didn't have to be connected. And there was not much of an internet way. And so I'm not a young doctor, but there was an opportunity for leadership because there was an opportunity to connect with the community in a new way. And they knew how to solve the problems, but they appreciated our health professionals, any of our caregivers, to be able to help connect them. And for example, in the United States, we were in a poor county, but not everyone had health insurance, believe it or not. One of the richest countries in the world, and some of my patients, or would-be patients, my neighbors, could not access care in an affordable way at all, period. And so we had to start a volunteer clinic to be able to serve a different part of our community. And it just took asking people to come together to do it. They were there to do it. But it took a little bit of leadership skills to do that. So those are the things that you can do as young physicians, as young healthcare professionals, young nurses in these rural communities, and it will make you connected to the community and to others.
Yeah, to me from Australia, I think that's just building on what you're saying is what we're finding in Australia is that we're attracting people to rural, nice rural towns and on the fringes of the cities and the coastal areas, but the real challenge is to get people in more remote and into small towns. And we know that the biggest driver for rural students is having a rural background. So with young people, I think leadership is important, but more important is mentorship, because our high school completion rates in rural Australia are probably just as bad as some of the developing world. And I think we really struggle to get the pool of graduates that are willing to take up those jobs in the future. It's getting to be a smaller and smaller pool of rural background. So we have to think creatively about high school completion rates and integrating education and health for the health policy people, and thinking about how we can creatively build those pathways to schools of nursing and stepways. I think learn from places like the Philippines, we do that really well. And those creative step ladders for programs, that would be really great. The other important thing is cultural competency. In Australia, one of our biggest health challenges is our Aboriginal population, and more than 20-year mortality gap, so morbidity gap. And so I think if we have young people who are trained in ways that are much more culturally sensitive and culturally competent, not just cultural awareness 101, things that they're immersed in those communities, I think that would be a great opportunity.
Yeah, I want to talk about the culture actually. But one thing is also that working in rural communities, one of the challenges that I see in Ghana is that sometimes the resources to work with are not there. And so yes, you are willing to work in a rural setting, I don't have the logistics. And sometimes even because the suitable gloves to work with, you do not get it. And there are instances where midwives will actually have to take babies with their bare hands when they got. These are some of the challenges.
I think Pratyush joined us from India. Do you have any thoughts about what kind of challenges you're facing in rural healthcare? Mike?
You have to go off mute.
Hi.
Hi.
Yeah, hope you all can hear me out. Yeah. So it's great to see all some similar faces. And so here in India, the thing is that what we are hearing from all over the world that people are losing jobs all over the world, but health is only the very unique sector where every day new jobs are being created, and the number of jobs is being created, and the norms and the candidates who are there to take up the jobs are very less. So it's a paradox situation in this health sector, and and this condition is much more worse in country like India, which is so densely populated. So it's a time we should think about innovation, how we can manage these doctor-patient gaps, and it can be used through the help of telemedicine, how the fraction of seconds we can connect all over the world. And similarly, with these kind of apps or e-health systems, we can connect with our patients and provide a continuing care to them, because most of the patients in our areas requires a continuous care. For the acute management, we do need to see them personally, but for the continuous care and for any advice if they need, we can provide it through these kind of telemedicines and through these approaches, so that we can, for the time being, we can manage the healthcare workforce shortage. uh, that's one of the point which I'd like to highlight here, and that's all. Thank you.
Thank you. So do any of you have any other positive examples of how your communities have tried to improve rural healthcare, or any other initiatives that you've been part of?
Yeah, in our country, when training is undertaken, the young doctors, the young nurses are actually exposed to the communities that they are supposed to work in. So they have a rural attachment, which is stipulated. At first, they should be 3 weeks. Then in another session, in another year, maybe 4 weeks, 6 weeks, they will have to stay there. They will have to stay in the community, get there and see what is happening there, look at the terrain, look at whatever is around them, so that when they get to be deployed, they don't get shocked. Because sometimes you can get the shock of your life. You are coming out of lines and you get there, there's not even a single light or anything that you could use, not even a candle. So you just have to be prepared for it, so that when you get there, you can actually cope with what is expected of you.
I could also add a bit more. Just recently, our minister opened up a health post, which is the new model now, which will be right in the community. Each village will have a health post that will be made by qualified professionals who will be working actually in the community. So that's the way we are also going to try to improve the accessibility of healthcare to the rural communities, especially in the remotest parts of the country. The one that has just been opened is actually one of the remotest areas near Mozambique, and it's furthest from all the towns. And that's, I think, the beginning. If we can have more of those, it means people will be able to access the minimum health care nearest to their own homes. They don't have to travel long distance, which will be helpful, particularly in maternal mortality and childhood mortality as well. Thank you.
Any other thoughts?
Again, the importance we found in having the learners, the young doctors, learning in the communities is that it gets what you talk about, it gets them reinforced on how to live in those communities and culturally adapt to those communities, but it also encourages young people in those communities to see medicine or health or nursing. So it is a circular effect of the bringing and involving communities in actually growing the next crop of medical students or nurses who will then go back to those communities and then start to build up capacity. The other big revolution that we're seeing around the world, I don't know, Mayor talked about the lack of cell phone towers, but in many countries that's now being overcome. Even in Haiti, where we do a lot of work, after the earthquake, all the infrastructure is gone, but it's not been replaced by fiber cables, it's been replaced by cell phone towers, and we're finding most areas we can actually connect up. And that's revolutionizing things. And we're very remote. We use e-consults a lot for the rural areas. And that's reduced the travel by a lot of patients that would have to make for consultations. And it's become very effective at supporting the rural health force by doing e-consults to the specialists when that's needed, and for chronic disease, complicated management. So I think we're at a really revolutionary time where technology is going to make us adapt to a different way of practice. So we'll help things out in some ways, but we'll still need the skilled people to deliver the babies, to provide that kind of acute care. but chronic care disease management will become somewhat different, and we need to adapt to that.
What Janine said before was really important, finding the reason why somebody wants to connect with rural and regional. It might be because they've got family there or they came from that area. But then having exposure was another thing that was mentioned, and I think our Brazilian counterpart said that it was by chance that she got exposed. So that's the season. So if we have a reason, a season, maybe we'll just get a lifetime of connect with people really becoming rural healthcare providers, whether that's a midwife, a nurse, doctor, or allied health, or the healthcare worker. I think it's really important to actually value that relationship that we all build with rural counterparts.
The question that I would put is that a lot of the research that's been done around recruitment and retention has been done with baby boomers, because they've been the people who've been there, and that's been a job for life group of people. And so we've emphasised the longevity of being in a rural community, in a rural town, and a rural career. I don't see that in my kids. That's not the ethos. It's not a job for life. It's multiple jobs in multiple places. So my question is, to what extent is the research that has been done relevant to documenting history as opposed to strategies for the next generation? And so I'd be really pleased to hear from the youth forum what the strategies are going forward.
I have a comment on that while others are thinking of a response. So this is what Paul has raised is actually not really new. I, with a group, did a national rural general practice study in Australia 20 years ago, 1997-98. And of the 1,800 respondents to the survey, we did 33 expected to retire in the community where they started in practice. And they were all quite old at the time. That most of the rural doctors, even then, were not expecting to stay in practice for their entire career in the same community. So this has been a changing scenario over quite a number of years. I think it's quite important for communities to understand that, because I still see expectations in communities that once a doctor comes to a community, that then that doctor's going to stay for the long term, even though that may not be the expectation of the doctor and the doctor's family. And so you have a mismatch of expectations, which then can lead to all sorts of problems. So I think that it is actually important that the question that Paul asks is a really important question to be asking of current students and new graduates about what their expectations are, and then helping to connect their expectations with the community, so the communities understand that if they're going to be assured of healthcare into the future, they need to connect with the current students and new graduates in ways that make those new graduates feel that they want to be in this community and live their lives with their families in the community.
And Paul, we actually asked that question in the journal Rural and Remote Health. We published on community APGAR data looking at physician attitudes in rural practice, but we took that data and the different things that might be important to doctors who live in rural places and practice there, and we asked medical students which factors they thought were most important. And at least in the United States, it tended toward people who were going rural. It was about, what can I do with my hands? Can I deliver babies? Can I cover the emergency room? And then in more urban-centric medical students, it was actually about schools for my kids. Is my spouse going to be happy? My significant other? And believe it or not, shopping rose to the top. I have some hope that, at least in the United States, Amazon still delivers to the world. We may overcome some of this with various, but I think it's very interesting. I think not all medical students are the same, and that's okay. And how do we tap into some of the special opportunities? I really like that. The reason in the season, we have those people who can be successful in rural be there. So we're completing a study with residents now, next, family medicine residents, but this year, just about what are you afraid of? What are you hopeful for? What's exciting? But also, what are some of the barriers that help support?
And I think we know that our generations below us on the X generation, and my nieces and nephews are wanting 4 careers in their lifetime. Why can't we make those 4 careers in health? I've been a flight nurse, I've been an educator, I've been a perioperative nurse, I've been a chief nurse, I've been an executive director of nursing. If we look at those domains, it's been in education, it's been in management, it's different things, but I've stayed true to health. And if we can actually engage in some way and look at the value proposition each of you want from your organisations, we might just be able to go for that. But it will take investment, and it will take you guys to let us know what you want and what you need to be satisfied for the lifetime in rural environments. So what might that be?
Give an opinion from a young doctor perspective, bearing in mind that this is my personal opinion. So I am not sure that I would ever be able to work in a job where I would be 20 years. I don't see myself doing that. I am interested in rural healthcare, and I do understand it's important to connect with the community. However, it is more likely that I will stay in a community maybe 5 years, maybe 10 years if I'm particularly invested in a certain area. But I'm more interested in what kind of development opportunities a position provides me. Am I growing? Am I developing as a professional? Or am I just staying static, which for me is not something I want to do. So once I start to feel like a job's not allowing me to expand my skills, to allow me to do different things, I'm likely to leave that job. So I think one of the problems rural has is maybe not having as many training opportunities, not everywhere, but in many parts of the world, not having seniors available to teach you things, not having the infrastructure, not having the equipment, not having access to having 3 days to go to an education program. I think those are all factors that discourage people from going to work in a rural area.
Mayara wants to comment just before we continue.
Sure, just to bring more things to the conversation. I do think that the isolation is a big thing. Like, you feel really isolated, and it's kind of, I'm repeating myself, but it is what happening. And even like if it's an infrastructure, I know that I have a leadership role in there, but sometimes could be a burden as well, not just a role. But you need to be the leader all the time, but you don't have any support. You're just forgotten where you are. You're just forgotten in the middle of the rural area, and you don't have stakeholders. You don't have support of government. You don't have recognition from outside. So it's much more difficult, and because of this, we need to bring and increase the rural discussion. Otherwise, we'll never ever have like more health professionals working in rural areas. My team is all like with it's all depressed because it's rural, it's far away, and it's hard to be all the time the whole model and being the leadership. And if you don't get anything back, if you are all the time being isolated, if you don't have any feedback from government and any feedback of stakeholders. It's different when we are talking about other parts of the world, but this is where I live. And it's hard to, like, I want a day off to study, like go and get more information, or 2 or 3 days, and we can't because we don't have any other doctor there. So it's much more difficult. And as we are talking about Brazil, that's a huge place with loads of places with no internet. So we need to be realistic on that as well. Thanks.
Patrice, do you have any comments?
So the thing is that in our rural areas, there are young doctors who are coming to practice in the rural areas. But if we see at the percentage among their background, mostly they are coming from the rural background. Though those who are born and brought up from that area only, they only go in those areas to practice. rural medicine. Otherwise, those who are hello.
Yeah.
Yeah, otherwise those who are there in the those coming from the urban areas, they usually tend to avoid rural areas because they get the luxuries of all the urban things which are available there. But in rural areas, the infrastructure is not there. They also feel doubtful about their career progress, that how their career will progress there in rural areas. What's the reward and promotion they will get? Usually, the promotion what they get in rural areas is that they will be transferred to in urban areas. That's the promotion is something negative. It goes negative for the rural practitioners. And the more thing is that these kind of attitude by the doctors helps in the growth of quackery. There are many quacks there who practices what's not evidence based medicine, but they have got a very a good approach to patients. They talk very nicely to the patient. They talk in their own languages. They have got the great convincing power. So in our medical curriculum, we are also not been taught how to interact, how to deal with the patient care. And that also in the rural context, where we have to see lot of things in the cultural context, in the way they behave, in their own religious beliefs. And in that we need to find out a middle path, how we can solve their problem. So there are various other things which matters when a young doctor decides to go to rural areas. Thank you.
Anyone else?
Yeah, just one, I think what worries me is that we are having more restricted definitions of what family medicine is. And that's happening in professional bodies and colleges, and I think probably in Wonka as well. And actually, if we're going to meet SDG 3 and have universal health coverage, we're looking at places like Africa, where actually our model of family medicine doesn't actually fit that clearly. So essentially, these people are family doctors, but they're doing other things as well. So I think we just need to define that. We need to be brave and expansive in our definitions. But all these colleges are becoming more and more risk averse. So they're looking and they're restricting and we're de-skilling family doctors around the world. So I've just got that concern that we can turn that around. Otherwise, the future for family medicine is going to be just a little box.
And that's except for, of course, the College of Rural Medicine in Australia, and it's proudly still part of family medicine general practice, but does have the curriculum that covers all those things. I think it is important that I think we need to recognise that people need to have careers after rural, but rural is an important building block to those careers. I think there's a bit of a myth. There's a few of us that are still out there, but there's a bit of a myth that rural doctors always stay out there. Most of my friends have gone to the city. They've done, however, 5 years or 10 years, thoroughly enjoyed it, and then gone back and done careers in emergency medicine, all sorts of fascinating things. Very few of them have actually gone back to urban general practice. But they've done lots of leadership roles, other roles, and I think we need to see that career as something that you can be well prepared for in rural. And then, because you're pluripotent, if you like, you've got this massive range of skills, you can even become a rural health commissioner.
If you're really unlucky. Bottom of the barrel.
It does show you how you can develop such important leadership skills, such important emergency medicine skills, such important other skills. And I think we need to see that as a real opportunity for people who want to have other careers afterwards, but want to actually experience in the heart what it's like to really be part of and work for a community. And I think that's often undervalued in our society these days, is the actual caring role. For God's sake, you get paid for it. You might not get paid as well as someone else, but you are getting paid to be a good person, really, which is lovely.
And I just wanted to add to that. I remember talking to Roger many years ago, and Roger said, well, actually, we're also public health physicians. And I think we tend to forget, in urban areas, you don't have that public health role. And even if, because leadership is about public health. And those are skills that we can take forward. We may not have masters in public health, but we've got huge knowledge about how communities work, how you build social capital. I would agree with Bruce that we're actually, we're making the leaders. We're growing the leaders.
Yeah, leaders who have experienced it, whether you intended to or not. If the clinic closes at 5 p.m., there's a 1 in 2 chance that you're the doctor after 5 p.m. stepping in the emergency room. So this understanding of whether a patient has money or insurance or not, but there's still the neighbor's house 3 doors from yours you walk past on your way to work. Those experiences stick with you, and they do something that allows you to have, like you said, a pluripotent skill set to be able to engage communities who have limited resources in whatever situation. And I think that is valuable, and it's a gift that rural business. It's something special.
So just picking up on those themes that John and Bruce and Dave mentioned, first of all, I described my list of characteristics of rural practitioners before. Certainly, opportunity to affect the health of the community at the whole community level. That's the public health physician sort of concept. And my favourite story of that is a rural doctor in a small inland town in Australia who was so effective in presenting the message about the connection between red meat and cholesterol and heart disease that the butcher shop started selling fish. And the other thing that in my mind what's been said is about generalism. So my headline of describing a rural practitioner is a rural practitioner as an extended generalist. And I really think that the time is now. There have been 3 World Summits on rural generalist medicine. Rural generalist medicine, there's a growing discourse about generalism in healthcare and health workforce education. And there are 3 key elements in the different definitions of generalism. The first is providing wide range of services. The second is, and the third is responding to the health needs of the population that you're serving. And I think, that's the essence of what we're talking about. That's whether you're talking about family practitioners or surgeons or other disciplines of medicine or nurses or pharmacists or other physiotherapists or other, it's so important probably everywhere, but especially in rural communities that the care providers have generalism competencies. And I think that's a key message that we need to be promoting and encouraging for our students and young doctors to be embracing.
And Roger, that's an attractive option. In a world where medicine is becoming more and more, people spend their time in offices, it's much more mechanistic medicine, that what you've said now is an attractive option to say, this is the alternative that we can take.
What do we feel would help us attract more students and young doctors to rural medicine? What would we need from our stakeholders and or government? Anyone have a comment?
Yeah. Really, if you look at it, I remember there was someone who highlighted the issues about education for their kids, entertainment, and all those things. If we could do at least try to provide some of those things in that rural community, we may find actually people feel more comfortable to go there. The environment is already good. There's going to be air, breathing, and other things, but we need also to provide facilities for entertainment, facilities for education for their kids, and even being able to provide them with resources to be able to work with in those communities. I think that would be very, very important.
I also feel it is better to take somebody who has been there to be there, rather than taking somebody who has been in town, they've never seen it before. They are taken in and they are actually thrown into that table, and they are supposed to provide service. First of all, they'll start adjusting themselves so that at least they can fit in. That is 90%. Therefore, I would have thought when we train, we also pick on children from those far areas who are used to it. So that when you throw them into a corner, they are not in a corner, they're actually in an environment that they are used to. So they get in, they get used to it, they don't mind their child getting to a school where there's a swimming pool because they've been using the rivers. So they don't mind because that's the type of life. So it's like if we are deploying people, we should actually deploy people by choice. To say, they will say, I want to go and work there because I know what is expected. Rather than saying you should go and work there because you were trained to be a doctor. They would not function properly. So I would actually look at our trainings and our schools to be more comprehensive in attending to what is required of somebody who's supposed to be working in the rural area than just assuming that we have got a doctor and they can actually manage it. I also wanted to add that, you know, in Zimbabwe, we find a young doctor who has just completed school, they are actually thrown into a district and they're supposed to be a district medical office. They've never been managing anything. They cannot be managed themselves. Now they're supposed to be a team leader and they're supposed to be managing the health of that very big community. It becomes a crisis in that guy's, you know, that child or that doctor's mind because they cannot even produce anything and they will be seen as a failure, and yet they are not a failure. They are not prepared to do it. So we should actually capacitate them as they grow so that they can actually get to where they are supposed to work, and we give them what is necessary for them.
So you need training in place that's broad and includes all those things, including leadership, and that's just so important in these communities.
And just to pick up on that, I think we're moving to the time where, again, the doctor has to be part of this healthcare team and not just the doctor themselves. So that means the management abilities you have. And we found in our setting, which is very remote and isolated places, that instead of trying to put one doctor in each community, we've clustered 3 or 4 doctors in an area, and they cover several isolated communities that are well staffed by a nursing healthcare team who are generalists, who then communicate closely to the doctors. So we've gotten away from that one doctor per community kind of thing, and then 3 or 4 doctors together are clustered to cover each other off, and they're happier. And have some time off.
Yeah. And that working the unmet need with the team is just so rewarding when you actually see the outcomes of that. And I think that's where we need to really advocate and speak up the positives, because many times when we get together, we are tired, we're exhausted, and the glass is half empty rather than glass half full. And if we want to share those dilemmas and get through them, they need to be discussed. But I think that whole collaboration, I've just been really pleased to be invited to be part of this forum today as a nurse with medical officers. And if we start to really look at how our care is provided across the world, it is in collaboration. And I think, you know, meeting the levels of exhaustion that we do see medical officers across the world dealing with, we've just heard that from Brazil, if there is collaboration and there's joint support with healthcare workers, you know, the race is not lost in actually making those sustainable development goals real.
Yeah, I was looking at the health system as a whole and how we can look at policies that will favor staff that will into rural areas. And so in the study that, for my master's study, I looked at optimizing performance of rural health centers. And we saw that in the rural area, local managers who are interested with HRH responsibility do not even have the knowledge of HRH. And so they are not able to design interventions that can improve the work of the health workers. And so the health system itself, and also looking at decentralization of HRH policies. So in Ghana, where I come from, even though our health system is decentralized,
aspect of HRH is centralized, and so recruitment is done at the ministry in the secretary, and then people are sent down to the rural area. And so in the rural area, you are not even as a local manager, you're not able to recruit when there is the need. Then it has to go up to the ministry and take so long. Also with promotion. And so you are in the rural area working to apply for promotion, and your promotion does not even come. Talk about internet training, for instance. So the whole health system has also needs to go through a reform. So if
Can I ask them?
Please.
Does anyone who's joining us have any comments on what kind of things could be done to help encourage young doctors and students to go to rural areas in their communities? Yeah, go on, Russell.
Hi guys, are you listening?
Yes.
Yes.
Yes, is everything okay here? I'm from Brazil. I'm an undergraduate student. I'm in the 4th year. And I would like to add some comments here. Well, I guess my contact with the rural was by accident too. Mayara presented to me. And well, for most of the students here, it is by accident. So I would like to reinforce this issue of rural awareness, because I guess it's really important. This need to be in our curricula. Brazil has some huge areas of rural, and Rio Grande do Sul. That is where I live too. But here, medicine, it's focused on the urban areas and everything else. So I guess that providing students an opportunity for experimental learning in rural areas is kind of an effective way to meet these challenges. When the student go on rural and see the scenario and learn not only by theory but on the practice, this phase on rural changes everything. So I guess it is an important way to captive attention of the student. Another thing that I thought about on this discussion is the internal electives. You know, in some schools we have this, after final examinations, we have this training in some areas, but here only a few schools have this internal electives in rural areas. But when we have this contact, I guess it's pretty easier for the student to understand what is the work on rural. And actually, I guess this matters a lot. And the use of technology too. But as Mayara said, it is pretty different from Brazil to Australia and other countries. Some places here we even don't have telephone signal. But I guess it is really important the use of technology to capture the attention of the students too for rural.
So I'm going to have to stop you for a second. We here in Dublin have to go, but please do continue the conversation online. And thank you all for joining us today.
Okay, so I do think that people in Dublin need to go. We can keep talking a bit during the closing of the Rural Café. At least Magda could come on the end, but anyway, I do think that we need to keep talking about the rural workforce and discussing these dams. And would you like to comment, Magda?
Oh, actually, hi everybody. I would like to know what you discussed in the forum. Could you resume, please?
Yeah, we were in the youth forum of the workforce for discussing how the workforce can move to rural and how we can change the paradigm of just being studying for urban and training for urban and go to the rural. Maybe Amber can comment.
Yeah, I just wanted to explain that there are several different discussions happening at the same time. So it's not just one forum where we're discussing one thing with something else at the same time. Discussions on how to improve funding. There are different organizations here discussing things. So a lot happening there. Days that after this cafe, there's a plenary where they're discussing specifically about improving the workforce in in rural, which is where Veronica has gone off to. So it'll be hard to summarize, but we'll keep you posted via Twitter.
Great. Do you need to go, Amber, because you are hosting the whole conversation?
No, it's me and Veronica are sort of tag teaming it. So Veronica has gone to report back what we've just discussed at the plenary, and then I'll stay here so we can our closing comments.
Okay, so maybe we can do the closing comments for each one of us. Just I want to bring from Sunanda Ray on Facebook. She joined us on here, and she's from Zimbabwe, and she commented a lot of the importance of the career pathway and including incentives for rural practice and district hospitals. She also comments on having multi-sectoral approaches and also this infrastructure at the place. And she asked for remember to speak about the Family Medicine Zimbabwe page so we can share it in our social media as well. And having more positive feedback and medical students will find a better education environment. And not just, you need to have more clinical exposure as well. So thank you, Sunanda, for joining us on Facebook as well and bringing your insights about Zimbabwe health care. So maybe we can move to our final comments.
Do you want to go ahead and start my own?
Well, yes, I can. And then maybe Andres can follow me. It was really great to be at this edition of the World Family Medicine Cafe. It wasn't easy to put this on. Thank you so much, Amber and Veronica, and all that is involved on that. It's great to see all that what we have commented and the need to see how that one size doesn't fit all when we are talking about rural, and to check that we need to keep growing the discussion and struggling for having space on this kind of conference to keep talking and discussing about rural. And thank you for all that joined on Twitter, on Facebook, and hopefully we can keep talking and discussing. Thank you so much. I think you're muted, Amber.
Sorry, doing too many things at once. I was saying thank you very much for those comments. And Jessica, would you like to give us your closing comments now?
Andressa, can you do your closing comment?
Well, it was really nice to be here, and actually, it was the first time that I followed the Twitter, and it's a rich experience following there the comments and the hashtags. Really great highlight. So I guess there is that. Congratulations, girls! Congratulations, Amber, Mayara, and Veronica too, for this and for everybody. It was nice.
Thank you very much, and thank you for joining us. Pratyush, do you want to go next?
Hi everyone. First of all, congratulations to Amber and Veronica and Myra to organize this Rural Cafe so nicely. And it's a great opportunity, I feel, because WHO Forum is one of the biggest forum for any medical professionals. And there the rural health is being discussed in so many places. Even after, as Amber said, that after this Rural Cafe, they're also going to discuss about rural thing. So I feel this is the taste of the season in this conference. So that's very important that we are giving emphasis to rural healthcare in these kind of bigger conferences. And then the next thing is to actually implement these all talks, whatever we talk in all these conferences, actually go to the last place and actually get implemented practically. Because whatever we see, whatever we talk usually does not comes to the reality, because still family medicine or the primary care is not a recognized specialty. There's no jobs in the name of family medicine specialist. We do have jobs as a internal medicine, pediatrician, gynecologist, surgery, but we don't have anything like family medicine jobs in rural areas. Although family medicine is made for rural areas, but we don't have any jobs. So these things are now the time is that this all the talks gets implemented actually in reality. So that thing now we need to see that everything gets a good support from all over the world.
Just to add, Pradyush is organizing the next conference in India. Can you just comment briefly on that, Pradyush?
Yeah. Thank you, Myra. We are organizing the next conference in April in India next year, and this conference, as a young doctor myself, we have our main emphasis on the medical students and young doctors. We are promoting it uh, so that more and more number of medical students and young doctors come and visit in this conference. And for young doctors and undergrad and medical students, we have organized the International Short Films and Arts Festival, because in the undergraduate curriculum you have multiple interest areas, like someone has interest in poetry, someone has interest in photography, in filmmaking. So they can also, in the conference area, they can also come and showcase their talent. And with that, they can also learn about rural healthcare, what's happening all over the world. So it's a great opportunity for everyone all over the world to come to India, visit India. It's a great place to be. You can visit some great historical monuments there near to Delhi. And we also have planned some rural health visits where you can come and see some hospitals. I don't think many of you may not have seen some 100 to 200 patients coming in a single day. That you can see in Delhi next year. That how we treat so much of patients in a single day. And that's one of the specialty where you can see the bulk of patients, how they come, how the long queues are there of patients standing next to the hospital. So that's the one thing. And then we have also planned some of exchange program also, so that you can spend around 3 days, 7 days, or 1 month kind of thing in any of the hospitals anywhere in India. We'll let you know in a short period of time. And the abstract submission is on, so you can submit your abstracts and register for this conference. Thank you.
That's excellent. Very exciting things happening. I already booked my ticket, so I can't wait to get there. And Magda, do you have any closing comments?
Hi. Are you listening? It's okay? Oh, nice. I'm just like to consider, Pratyush, that we could or should, I don't know, enjoy the moment in India to write some documents to support the policies in development countries like India and Brazil, that Brazil is, like, you told, we don't have any places we have places, but it's not formal places to work, like family doctors. Actually, anyone could work in these rural areas here. So we have clinicians, obstetrics, and it's very hard to get them to work in rural areas, but the family medicine is not recognized to this the best specialty to work in rural areas, but we don't have policies to support that. So I would like to suggest that in India we could write some documents to support and policies in India and Brazil to a strong family medicine in these rural areas. It's just this.
Thank you. That's definitely one of our agenda of this conference. That's why we are doing it, that conference in Delhi, because Delhi is the area where all our politicians, every health ministers, they are all living there in Delhi. So we are going to invite them there, and then we are going to discuss it with them in the close quarters, so that we can make a change in our policy, so that they at least they recognize that family medicine is a specialty for the rural population, and together we can bring out a positive change in the health indices.
Okay, very nice. Lots of exciting stuff clearly going to happen there. So thank you guys very much for participating in this chat. Thank you very much for your ideas and sharing in the discussion. It's been really interesting as always, and I'm sure everyone who's watching us on YouTube and participating on Facebook and Twitter learned a lot as well. The only closing comment I have is the same message I've been saying from the beginning, that we're not the only crazy people in rural. So we need to just carry on doing what we're doing. We are having an impact on communities, and we are changing to improve healthcare of people in rural and remote settings. So thank you very much. We'll see you guys next month for our next Rural Cafe. If not, we'll catch you at Delhi. Hopefully we'll have a Rural Cafe there as well. So thank you for joining us, and see you next time. Okay. I think we're off air. All right. Bye-bye.